And we're live in 5,
4, 3,
2,
1.
Well, good morning, everybody. My name is Jens Chapman. Cordial greetings and welcome from Seattle, Washington. October 1st is the date, so beginning of a new month, and our fellows have just changed rotation, so it's amazing how fast the academic year goes by. Today, we have a very special feature. We have eminent members of the Scoliosis Research Society here today. We just finished our annual meeting in Charlotte, North Carolina. And one of the eminent task forces of this fantastic society is dealing with frailty, as we are seeing more and more sick people with more and more diseases, and that includes significant spine diseases. The question of who and how can we make sure that patients benefit from surgeries, from these sometimes very large reconstructive surgeries. So the subject of frailty inevitably came up, and the SRS created a whole task force. And it's a really noteworthy undertaking. So today's session is entirely dedicated to frailty, and we have great experts from around the world. A featured speaker will be Dr. Camilo Molina, who's a neurosurgical colleague who does a lot of deformity surgeries and oncology procedures, and he's well known for his beginning and very novel work of augmented reality and robotic spine surgery. For introductory purposes, I'll ask Dr. Robert Eastlack from the Scripps Clinic, well known to everybody here, to give a couple of introductory statements about the SRS's mission and how this all came about. I thank you all for joining us today, and to the members of the SRS Task Force for lending the expertise here.
Good morning. Can you all hear me? Okay.
Yes.
It's great honor. We're happy to collaborate with SSF. The SRS, as you heard, established a task force on frailty and senescence, given the advancing age of the patients that we're managing. And we tried to coalesce a group of experts to look into different pillars of frailty and means by which we may be able to both research and engage those patients more carefully and successfully. The group has created several reviews, one of which Camilo stewarded. We've looked into things such as sarcopenia, bone health, biomarkers, and we're advancing into radiomics, so utilizing different imaging and AI to assess the factors of frailty and senescence. And finally, we'll be generating some reviews on digital or dynamic health metrics, and then finally digital wireframes, which will lend towards what we call digital twinning or predictive analytics at a higher level. And so all of the work that we're doing is hopefully going to feed most of all the curiosity to generate research, and for today's purposes, start giving all of the attendees a look at how we're starting to perceive, evaluate, and prehab, intervene on patients before they undergo surgery, or in some cases, not undergo surgery if the data suggests that. So Alikos has helped put this together as well, so I want to acknowledge him, and without further ado, we can let Camilo take the reins and wade into the sarcopenic realm and what he learned, and give us the information that we need to begin to treat our patients more effectively.
Thank you, Bob. Tim, if you can go ahead and start sharing our slides. And I really appreciate the opportunity to share my experience with everybody this morning. I'm going to be, setting up the stage here for Tim Bowie, who's one of our medical students who did a whole year of research with me and is soon to be a neurosurgery resident. I think he knows this subject as well as anybody. But to frame this, I'll go ahead and get started. If you can show us our next slide here. None of the disclosures are relevant. So sarcopenia, this is something that's, I would say, a hot topic right now. It's something that a lot of us are talking about in the setting of adult spinal deformity. It's a new metric where we think about the development of adult spinal deformities, not just the failure of the bone and the reshaping of the bones and the wedging of the bones, but as well as the failure of the discal ligamentous complex and this progression of sagittal and coronal plane deformities that ultimately results in the obvious cosmetic deformities as well as severe disability. But we've really all been dealing with this and can recognize it for quite a long period of time. And when everything manifests, the failure of the bone, the failure of the discal ligamentous complex, and the failure of the soft tissue envelope, we see these very severe deformities. And in particular, we know and we can recognize them in some of these neuromuscular patients, particularly patients with Parkinson's disease and camptocormia, whose failure of the soft tissue envelope is not just the decrease in muscle bulk, but the decrease in muscle function and the lack of neuronal input to those muscles that results in these severe sagittal plane deformities, complete global deformities, chin and chest deformities, excessive thoracic kyphosis, etc. So I want you to think about these patients as we in how they present to your clinic as Tim shares some of his work today. Go ahead, next slide, Tim. And then I will also have you think about these two patients. These are two patients that I treated within the last 2 months. On the left, you see a patient who had a lumbopelvic fusion with an iatrogenic lumbar flat back deformity and subsequent development of proximal junctional kyphosis that is now rigid. And on the right, you see another patient also had a iatrogenic flat back deformity, also rigid, does not have quite as much proximal junctional kyphosis and seems to actually have a somewhat hyperextended upper thoracic spine as a compensation. Both of these patients share the retroversion of their pelvis, but the one on the left, of course, has an exaggerated thoracolumbar and upper thoracic kyphosis, and the one on the right does not. And so with that in mind, and we'll circle back to these patients later, I'll let Tim take it from here.
All right. Thanks, Dr. Molina. And so kind of before we go on to speak more about sarcopenia within spinal deformity in specifics, I wanted to talk a little bit more about sarcopenia in general. And so to define it, we want to think about how sarcopenia is a metabolically driven catabolism of skeletal muscle that occurs with aging and senescence. And classically, it's been considered a general representation of frailty and health status. And the reason for that is because there's a robust amount of literature on the association of sarcopenia with these general adverse outcomes. So things like falls, disabilities, hospital length of stay, ICU admissions, mortality, so on and so forth. And as we look more into sarcopenia and learn more about its biomechanics and pathophysiology, we begin to understand that there's a coexistence with many other metabolic diseases and with complex interrelated signaling pathways. And so, for example, there's been a lot of research on osteoporosis and sarcopenia, deemed osteosarcopenia, and also sarcopenia and obesity. And really, these studies have shown us that the importance of the crosstalk between the muscle and the bone via these cytokines and chemical messengers. And so what the studies on sarcopenia haven't really considered is that spinal deformity itself has many unique complications that are currently underexplored. And so the field has been moving towards the idea of general sarcopenia versus a more spine-specific sarcopenia, in which we can begin to evaluate adult spinal deformity mechanical complications, which are not really present in other disciplines. And so with that said, a universal principle in sarcopenia is defining muscle quantity and quality. And across different disciplines that use sarcopenia, it's generally been measured in a systemic manner, in which the whole body mass and the muscle integrity has been considered. And currently, it's not possible to or feasible to directly test the function of every patient's muscle without biopsy, though this idea of general sarcopenia has used many different proxies to represent this fundamental principle of quantity and muscle quality. And so, for example, the dynamometer measures the hand grip strength, which is used as a proxy for overall muscle strength. And then functional tests, such as a timed up and go test, can measure muscle function and use. Recently, we've also been using advanced imaging to represent body composition as well. And so in 2018, the European Working Group on Sarcopenia in Older People created a consensus to standardize these different criteria for defining general sarcopenia. And they created these principles, these criteria to be consistent with the principles of this muscle mass and function that we talked about. And the 2018 consensus was designed to be flexible and easily adoptable, and hence a wide variety of measurement modalities were included along with its redundancies. And so strength was measured directly by force generation with the dynamometer, or indirectly with physical performance with metrics such as a chair stand test, timed up and go, gait speed, those type of exams. And then with imaging as well to supplement these findings. And so these criteria defined patients as sarcopenic if they met the thresholds for 2 of these 3 criteria in muscle strength, mass, and physical performance. It should be noted that none of these findings, none of these criteria specifically measure the quantity or quality of spinal muscles, which are more of our interest in ASD. And so given the variety of measurement modalities, there comes along with it a slew of diagnostic cutoff thresholds. And it's been found that these thresholds don't have strong internal agreement. And so historically, DEXA has been used as a gold standard to measure the muscle patency. And as we know in practice, we commonly use DEXA to assess bone composition and provide clinical information about density for diagnosing osteopenia or osteoporosis. Well, it's been found that this technology can be extended to body composition, as is often used in sports medicine. And so this can allow us to quantify skeletal muscle mass and look at the general distribution. And so peripheral versus visceral distribution of fat and muscle, and also provide some information about the muscle degeneration in the terms of fat infiltration. And DEXA has been a useful tool because it addresses both the muscle quantity and quality that we've been talking about. However, comparing DEXA with other modalities, a 2024 study on a single cohort of cancer patients had wildly differing prevalence of sarcopenia based on the measuring tools with different sensitivities and specificities. And so with all of this in mind, we can think of general sarcopenia as a tool to understand the tolerance of a patient to the general stress of surgery. But it really doesn't address the questions specific to spinal deformity and spine surgery. For example, the long-term mechanical stability of a planned construct. And so to begin thinking about these concepts, we want to start thinking about the unique biomechanics of adult spinal deformity and the challenges and considerations that are not necessarily found in other types of surgery. And so when we form a long segment fusion, we create a lever arm with the upper instrument vertebrae as a pivot point. And with gravitational downward forces acting on the non-rigid rostral spinal segments, this can clinically manifest as a proximal junctional kyphosis, which is a complication I'm sure many of you are well aware of. And so with this complex spinal ecosystem, it establishes the patency of the fusion construct. So not just the bone, but muscle, weight distribution. It's really the group of relationships, not just the muscle, that determines how well this construct may persist. And doing so, we must think about how well the muscle exerts force on the bone, the patency of the muscle itself, and as Dr. Molina mentioned earlier, neurologic input. It's really a very complex niche of bone environment. And so it's been posited that the ability of paraspinal muscle groups to contribute to the stability of the spine has been closely linked to the success of long-term fusion. And so how sarcopenia comes into play is that this muscle degeneration and senescence really compromises this stress transition unit of the spine. And so to address these unique aspects of deformity surgery, researchers have begun studying spine-specific sarcopenia, or in other words, focusing the concept of sarcopenia that we've talked about previously in generalized sense to the paraspinal compartment. And as we continue to explore the fundamental principles of sarcopenia, we begin using a combination of imaging and direct testing of muscle fibers to assess the muscle size and muscle quality. And for direct testing, there have been measurements using targeted force generation. The example here being a direct back extension measurement. And so with the modern technological advancements in imaging, machine learning, and increasing accessibility of MRI, we see a convenient, consistent, and high-quality strategy for assessing the quantity and the quality of muscle in a specific manner. And so as previously used in general sarcopenia, DEXA was found to really lack topographic resolution to distinguish the relevant paraspinal muscle beds. On the other hand, MRI provides reasonable distinction between relevant muscle groups and the noise, the remaining parts of the image that are less useful for us as spine surgeons. And in combination with machine learning and automation, MRI really provides potential for quick, consistent, and comprehensive data for all these aspects of sarcopenia that we're interested in. And so what's been done in the literature so far is that measuring quantity has been the cross-sectional area, particularly of paraspinal muscles, the multifidus and the erector spinae. The quality of the muscle has been measured as fat infiltration percentage. And so this looks at how much fat is within these muscle compartments. And this is used as a proxy for the degeneration and for us to understand the remaining functional patency of the muscle. And notably, the psoas muscle, while paraspinal in distribution, primarily functions as a hip flexor. The current research supports this distinction, thinking of the psoas muscle as a general sarcopenia metric, but in showing a lot of correlation between so the correlation between psoas patency and ASD complications has been relatively inconsistent over the literature. And so in an unpublished narrative review, we found a collection of papers evaluating sarcopenia in ASD and looking at proximal junctional kyphosis as a failure, proximal junctional kyphosis and failure as the outcome. There have been mixed results in which some studies have found general sarcopenia to have no predictive value with these outcomes, whereas other papers have found a significant correlation. On the other hand, when we looked at spinal sarcopenia, so again, the cross-sectional area and fat infiltration percentage, there have been a lot of papers with significant correlation. And to provide a few examples, a study in 2023 by Tsutsui had found that fat infiltration of the paraspinal muscle, so the erector spinae and multifidus, at the upper instrumented vertebrae had a strong correlation with our proximal junctional kyphosis and failure, with an odds ratio of 1.97. Interestingly, this study had also looked at osteopenia via Hansfield units of the spine and the cross-sectional area, and found that neither of those significantly predicted PJK, PJF. Another paper by Park looked at the erector spinae specifically and looked at the cross-sectional area at L4 and L5, so regardless of how long the fusion was. And using this metric, they had found that the odds ratio was 3.54 in terms of predicting PJK and PJF. And so we can see the potential of looking at spinal sarcopenia and understanding potential future complications in spine surgery, in spinal deformity. However, as it stands, the research currently has similar limitations to general sarcopenia in that there's persistent marked heterogeneity in how sarcopenia is defined and reported. Even in these two papers, one of them looked at sarcopenia at the upper instrument vertebrae, and the other looked more caudally at the L4, L5 segments. And so with all this context in mind, it begs us to think, how can sarcopenia be useful in patient care and in clinical practice? And so naturally, the first thought is, how is sarcopenia modifiable? And currently, the evidence really is limited to general sarcopenia, given the novelty of spinal sarcopenia as a concept. And even with that limitation to general sarcopenia, there's only enough literature to really recommend two therapeutic strategies. The first line being resistance training. And so a few RCTs have shown that TRX suspension training, shown here on the left, which is really a body weight resistance exercise, have shown improvement in sarcopenic biomarkers, functional abilities of elderly patients who underwent a controlled program without additional supplementation. As a second line, the evidence really shows supplementation and nutrition optimization to also yield positive results in decreasing sarcopenia. And so outside of directly treating sarcopenia with these two limited metrics, we can also consider creating surgical plans that incorporate muscularity and function into consideration. And so with the two examples that Dr. Molina had provided before, for a patient that might have excessive thoracic kyphosis from what would be a lack of paraspinal support caused by sarcopenia, might benefit from extending a planned construct to support this region with evidently poor muscular support. Meanwhile, a patient that had that iatrogenic degenerative flat back with what seemed to be excellent rostral paraspinal compensation might benefit more from a shorter and less invasive construct given their intact musculature. And so looking towards the future, with our increasingly advanced understanding of the pathophysiology of sarcopenia, this opens the door for unique, creative chemical modification. And so some of these future opportunities include biochemical manipulation with things such as myostatin inhibitors, osteocalcin, and really the concept of a comprehensive approach for a structural problem begins to manifest. And as we begin to manipulate the crosstalk between organ systems, we have this opportunity to do so on a targeted chemical scale. And so, for example, modification of localized spinal musculature, as we've been talking about. As it stands, paraspinal musculature is primarily type 2 fast twitch fibers, which provide a dynamic regulation of posture. And with aging and senescence, there's biochemical signaling found to transition these muscles to type 1 slower twitch fibers, which functionally provide less dynamic stability, particularly after adding a construct and excessive lever mechanics. And so thinking about what we know about sarcopenia and the pathophysiology, we can consider that we can posit that reversal or prevention of this change could greatly impact these mechanical outcomes. And so throughout the last year, the Scoliosis Research Society had formed that task force on senescence and frailty and reviewed this data and provided a few general recommendations. And these recommendations were created with a goal of identifying future opportunities to further develop the use of sarcopenia in spinal deformity research and practice. And in general, these recommendations really emphasize the consistency and comprehensive practices in reporting standards. The current physiologic relationships between sarcopenia, spine deformity, and other metabolic processes are obscured currently by research inconsistency, looking at different compartments, looking at fat infiltration percent and cross-sectional area, either in the upper instrument vertebrae or more caudally or more rostrally, just throughout the spine. There's been not one great way of describing it that could encourage multi-institutional collaboration and data comparison. And so these recommendations really have a goal of efficiently creating standardized guidelines for us to effectively move forward. And so with that, I think we'll have Dr. Molina continue talking about his cases.
Thank you, Tim. That was a great summary. And I think it's important at this point, perhaps, to summarize some of the important things that you have put forward. A, that there is this very big distinction between general sarcopenia and spinal sarcopenia. And it's not to say that general sarcopenia is not important to us and that we shouldn't care about it, because it is a general marker, a biomarker of that patient's general frailty. And that will significantly impact their perioperative outcomes, their wound healing, length of stay, perioperative complications, etc. It's a marker of how well that patient is going to tolerate the sterile trauma of a large surgery. But it does not necessarily correlate very well to our short and long-term mechanical failures, as we've seen through the data, that is really most greatly impacted by the soft tissue envelope directly in relation to the spine, and those being those extensor muscles, the erector spinae and the multifidus muscles. And if you were disappointed like I am as I delve into this literature, there's nothing really modifiable right now that we can do. A lot of these patients are so debilitated that if you say, go do TRX extensor training, they're going to probably look at you and think that you're crazy. So, not to say that they can't undergo prehabilitation, but it's sometimes likely unpractical that they're going to be able to meaningfully change the quality and function and density of those paraspinal muscles in preparation for those surgeries. And thus, it, in the current state, without some of these promising new biological medications like myostatin inhibitors and other anabolic treatments, we currently likely the best we can do is to consider the quality of that muscle in terms of whether we need, for something as simple as wound healing, whether we need complex paraspinal wound flaps to get good tensionless closures, and the length of our constructs. Now, if we think about at least the length of our constructs, and we think of it from spinal pelvic angles, which is, if you don't know me, something that I'm very passionate about, because I think these are brilliant ways to measure global and regional alignment, because they're not postural measures. They're theoretically fixed measurements that are not prone to things like pelvic tilt and the other compensatory mechanisms. We can begin to conceptualize and provide objective measures of risk of failure in relation to the state of the spine above a construct. This is data from the ISSG by Jeff Hills. It's currently unpublished. We have similar data, but essentially, if you compare the C2 pelvic angle and the T9 pelvic angle, T9 chosen as the UIV +1 to the common T10 to the pelvis fusion, and you look at the offset of that angle, and then you retrospectively calculate the risk of a proximal junctional kyphosis or proximal junctional failure, depending on what the offset of that angle is, you see that after for example, a 14 degree delta of that angle, the risk of proximal junctional kyphosis for a lower thoracic fusion is 50% versus for a high thoracic fusion is about 12.5%. And so it's, more than 4 times greater risk of proximal junctional kyphosis. Now, conceptually, this makes sense. You see this patient has exaggerated thoracolumbar kyphosis, and given how anteriorly pitched they are, you would intrinsically or perhaps intuitively want to make this decision, but data like this can significantly increase your confidence, not only in choosing that surgical plan, but also in communicating that plan to the patient. And it allows us to study this as well. We have looked at this data, not just looking at the T9 and C2 pelvic angle, but really looking at the offset between the C2 pelvic angle and whatever the UIV chosen was, and have found similarly that after about 10 to 11 degrees delta, you need to extend that fusion up until that degree is less than 10 degrees to make an impact on that proximal junctional failure. And this is a result of the patients not just having failure of the disc and bone complex, but also of their soft tissue envelope. Let's go to the next slide, Tim. Because a patient like this, who is no longer able to compensate in their upper thoracic spine and their thoracolumbar junction, is essentially telling you that despite the tremendous amount of neural input that our brains and our cerebellum exerts on our extensor muscles to want to maintain a horizontal gaze, they're incapable of doing so. And so even though we haven't measured this patient's paraspinal musculature, there is no functional testing to do so, we know that it's likely malfunctioning and incompetent. Otherwise, they would be compensating like some of those other patients I showed you earlier. And thus, in a patient like this, you have to plan your correction to extend to the upper thoracic spine. And then we're able to get a good functional result. Next slide, Tim. In contrast, the patient like this, who has had this iatrogenic low flat back deformity created through a multitude of prior surgeries, they're showing excellent compensatory ability above. They almost have a somewhat lordotic to neutral thoracolumbar junction and a normal upper thoracic kyphosis. And thus, a patient like this simply needs to have a 3-column osteotomy across the iatrogenic flat back deformity, and the fusion was only extended 1 level higher. And we can see that you can restore excellent sagittal balance without having to go long in a patient like this. The next slide, Tim. And so we go back to these 2 patients that I treated recently. The patient on the left developed this excessive thoracic kyphosis, not just as a result of the failure of the soft tissue envelope, but now this went untreated for an extended period of time. So it's a rigid thoracolumbar kyphosis and an iatrogenic flat back deformity. This patient is likely going to need 2 3-column osteotomies and an upper thoracic extension to achieve a neutral balance and a long-standing good result to their construct. The patient on the right, in contrast, shows excellent compensatory ability, not just in her ability to retrovert her pelvis, but also in to maintain a close to neutral thoracolumbar junction in hyperextended upper thoracic spine. Let's go to the next slide. So you can see that the 2 very different construct strategies. The patient on the left underwent the 2 3-column osteotomies, 1 in L4 and 1 at the thoracolumbar junction to achieve neutral balance, elimination of the pelvic tilt, and a neutralization of the C2 tilt. The patient on the right, in contrast, only had the fusion extended up to T10 to perform a decompression that had developed at the adjacent segments, and then a 3-column osteotomy at L4 to restore her sagittal balance. And you can see post-operatively, these x-rays were recently done. Her pelvic tilt is eliminated, and now she has a neutral C2 tilt, and the normal thoracic kyphosis has been restored as she no longer needs to compensate. Now, we go back to the very original patients that we presented when it's something so severe that there is a global complete failure of not just the structure of the bone, the structure of the disc, and the soft tissue envelope. These patients need extensive surgeries. The patient on the left here underwent a C2 to the pelvis fusion. The patient on the right here is something that is actually the first time I've done this. Cal Kabesh taught me this. Is someone that you may want to do a C2 to the pelvis fusion on because of everything we've talking about. He's advocating that we do smaller fusions and apply these temporary tethers. Essentially, he percutaneously places an iliac bolt and passes the rod up to the construct to provide this temporary support while the patient gets used to the new position of their construct, in the hope that at 3 months it can be removed. And if there is no distal junctional failure in the short term, they can undergo a shorter fusion. If there is evidence of that potentially developing, then the C2 to the pelvis fusion can be staged to not put the patients through these highly morbid procedures when they're already obviously quite frail at baseline. So with that, I will leave you guys with food for thought and take any questions.
Dr. Molina and future Dr. Buie, that was a fantastic presentation, very thoughtful, all the way from basic sciences to the complexity of what's going on with the spine. And I always will stand on my bandstand, especially when I hear a lecture like this. The spine is an organ, it should be considered as such. It fulfills all the criteria as such, and we can see how the spine can undergo an organ failure. So enough of my bandstanding, but amazing cases also. We have a couple of cases coming, but let me ask a big picture question to you first, and then to Dr. Molina. And we have a couple of other members on here. Dr. Bervin is still on from what I see. Of the 3 big entities that surround spinal deformity parameters, osteoporosis, and muscle health, sarcopenia. Dr. Buie mentioned one study on this, but triage those from most important to relatively least important. What's the triage of those 3 large entities in terms of the impact?
And feel free to correct me if you feel otherwise, Dr. Molina, but my understanding from these studies, and particularly that one study that looked at all 3 of those, so the bone health, the muscle patency, and the spinal pelvic parameters, really shows that it can't be really thought about in isolation. I think, as you had mentioned, the spine is an organ, and kind of like a tree, not just one component of the tree keeps it alive. And so not just one component of these of the spine can keep the whole thing alive. And so I think that with the advent of more complex machine learning models and artificial intelligence, we really can encapsulate these complex relationships in a more feasible clinical manner. And so I think, to answer your question, it's really not possible to say which one is most important versus which one is least important, as all of them really contribute to the health of the spine.
So
I completely agree with that, Tim. I think we're getting closer to, that big data, predictive analytic understanding of how all these complex relationships come together to give us a bigger sense of risk. That's what we're doing is trying to de-risk these monumental procedures for people. I think practically today, there's things that are in our control and things that are not in our control. So things that are in my control is whether I choose to operate or not. That's the first thing. And so if a patient has frank osteoporosis, and you got to remember when somebody's not negative 2.5 T-score, that means that there are 2 standard deviations outside the mean. That means that essentially there 2.5% of people have weaker bone than them. That's really food for thought, right? Because we're talking about the right-sided tail end of that curve. So their bone is quite weak. So if they're more negative than that, and profoundly more negative, -3, when they're 97.5, 99.5% on the tail end of that curve, I will not operate on. The only times that I will is if essentially someone's holding a gun to my head and they're losing neurological function and I have to do something. But if that's not the case, then it's really unlikely that there's something that I'm going to be able to do that is going to have a long-lasting result, because the substrate is just simply not going to hold the biomechanical construct. The other things that are in my control are how long of a construct I do. So we talked about global sagittal parameters and the quality of the muscle is evidenced by their standing posture and the evidence on the MRI. And I think I can control how big or short of a construct I do to get the patient a lasting, meaningful result. I think my goal is to eliminate compensatory mechanisms and minimize reoperation rates in the big picture, while obviously trying to decrease their pain in a meaningful way and restoring and preserving neurological function. And so if I think about those things, the things that are in my control then from a surgical standpoint is achieving biomechanical balance. And from that perspective, I think we are becoming increasingly and progressively more thoughtful in making biomechanically more balanced constructs that make sense from an engineering and physics standpoint. Not so much, as you get older, you're more forward pitch and all these things. A lot of those things don't really hold up to the truth of balance and gravity. We need to really be more thoughtful about making constructs where the UIV is horizontalized, where the tilt and the slope of the disc where we're stopping is not subject to forward shear stress, and concepts like that. That's where I think we're going to make bigger impacts in decreasing these mechanical failures.
Great stuff. Dr. Eastlack and Dr. Molina, with your permission, let me ask Dr. Bervin, because he has to run off to a faculty meeting that was urgently scheduled. Sig, are you still there? Can you unmask yourself? Sig Bervin, San Francisco. If I can't get a response, I'm going to ask Dr. Eastlack. Dr. Eastlack, so you've given fantastic lectures on alignment, angles, and everything. Where are we with calculating a frailty score now? There are multiple different frailty scores. I think I heard you talk at SRS about that also. Is there one better frailty score than others? By the way, Dr. Molina, is that muscle milk that you're drinking? What are you drinking there? Want to hear your secret. Free advertising. Celsius, okay.
Celsius.
All right, no muscle milk.
It's a great question, Jens. I don't think we've gotten to the point where we have the one frailty index. I mean, Edmonton's obviously one. I think we're going to get to the point where we're as I mentioned earlier, going to lean on real-time digital sort of metrics, looking at patients' gait through wearables, their speed, the way that they ambulate, get out of chairs. I think that will, in the end, probably be where we end up in terms of better metrics for frailty. Right now, as I said, we use the FI and the Edmonton, and then more practically, the get out of the chair and the grip test tend to be pretty well correlated, but I don't think they're as good a window as we will eventually get when we harness the technology that we have at our disposal and utilize it for the patients that we're addressing. And just to add what Camilo and Tim talked about, right now, we know there's an interaction. I don't think we've understood it as well as we need to, but sarcopenia and bone health really go hand in hand, and there's a complex interaction between the two. So I think you really can attend to both in a little bit of a combined attack and have a positive impact on both. So prehab, where you're focused on maybe the sarcopenic element, will have a material beneficial impact on the bone health, even though we may still use pharmacologic agents to help with that. And I think that those, in terms of priority, my sense is those will probably be greater than our mechanical side of things, but they're both very, very important. I think you can get away with more if you you can get away with less precision if you attend to the bone and muscle health, and get away with a lot less if you don't. So I don't really have a good way to hierarchically place them out. I think they're all really, really important, and we're really early, I think, in all of them in terms of understanding how to intervene and do them better, manage them better.
So should I, and this question goes to both you and then Camilo, should I now order a couple of Jamar grip meters for the clinic? Should I have my medical assistants do a stand up and a tug test, more or less, and go testing, in addition to measuring fatty infiltration, which we're already doing? So should I get these grip meters and have the medical assistants learn how to do a get up and go test?
Outside of research, I'm not totally sure. I don't know if that you can apply it prescriptively quite yet, but my personal opinion is I think it helps. I think it gives you a sense of how much more prehab to do, and maybe when not to pull the trigger, as Camilo talked about, when to say no. This patient's just not going to do well. But if we don't gather that information now, we can't generate the predictive analytics to help us be better in the future if we just sort of ignore it. So if we do some basic things like that, even on an individual basis, we can start getting a sense of where we fall short. But as a group, when we coalesce this data, we'll be much, much better.
Yeah, and Jensen, I think it's important, those two tests that you talked about, those are well-validated tests to tell you about the patient's function with respect to their general sarcopenia and frailty, but they are not at all validated, nor are they predictive of spinal sarcopenia. And so while they may tell you the patient's ability to handle the invasiveness of your planned surgery, whether it's a big spinal deformity or a liver transplant or whatever, they may not necessarily inform you in terms of the longevity or planned surgical correction.
How long should we prehab patients, especially if you have some neurologic compromise? I have on my laptop right now my first patient in the clinic, and I'm already basically trying to apply the lessons from today. She has a terrible stenosis at 2 levels, but she has an undeniable significant degenerative lumbar scoliosis. She's also pretty large. So how long do I tell a patient with a significant stenosis that they have to prehab before they can have reconstructive spine surgery? And what should they do practically? Camilo, do you want to take that first? So assume it's a mid-70s lady with pretty significant stenosis, not usual lumbar spine, degenerative scoli, spondy, 2-level, pretty significant stenosis. On first glance, it doesn't look terribly osteoporotic, but She has clear neurologic compromise, but she's probably not at all prehabbed. But if there's stenosis, if there are significant neurologic symptoms, how long and what should we do prehab-wise for these patients?
And I assume by neurologic compromise you mean perhaps claudication and a painful
Bingo.
radiculopathy, but
Yes.
not a motor
Yeah.
deficit, correct?
Yeah, thanks
And
for
so
clarifying.
I think it's important that we understand the healthcare environment with which we practice. If I write an order for prehabilitation, often that may not get approved by their insurance. They say, "What do you mean? You're just going to rehabilitate in preparation for surgery and use up their benefits?" That's not going to fly. So, in general, these patients, they're not time-sensitive surgical emergencies. So I'm booking those people out 8-10 weeks out, and I say, "Look, it's unlikely that your case is going to get approved if you don't participate with preoperative physical therapy at the very least within the last 6 months. And I have a very detailed type of physical therapy that I want you to participate in." One of the things that I found to be helpful is the McKinsey method, which is a series of spinal extensor and core strengthening exercises. I say, I really want you to participate in this. The worst case scenario is that, you can't get through it and they discharge you. Neutral scenario is that you do it and you're still in a tremendous amount of pain and we go through with the surgery, but at the very least you got some conditioning out of it. And best case scenario is you actually get better and you come back and say, "I'm not quite ready for surgery." And I have very little resistance from the patients and or the payers taking that approach.
Dr. Eastlack at the Scripps Clinic. So we've talked about the three big dimensions of alignment. Kudos to the ISSG for really having taken that to a higher level of sophistication than ever before. Osteoporosis, again, multidisciplinary, and now sarcopenia. Talk to us a little bit about the other dimensions like significant opioid use and depression, psychosocial isolation, etc. So how much do those tie in? Because I'll just give you my vantage point. I see a strong tie-in between depression and sarcopenia. A lot of these people have just given up. They have become inactive, etc. But is there a tie-in that we as spine surgeons should kind of explore more diligently, like sarcopenia and depression and opioid use?
I think it's critical to attend to that. Practically speaking, I find that very challenging because it's such essentially a resource deficient area to manage. Getting people psychotherapy, psychiatry assistance is probably the most challenging thing that I deal with. They just don't have the availability, the access, and oftentimes they don't have the wherewithal personally to engage with that. But I think they are linked. The studies are, I think, less prominent in terms of the impact of those things, but it's definitely real. We've done some of that work with ISSG on depression and opioid use, and there is some correlation with outcomes. To my knowledge, not as much in association with sarcopenia, but it has to be there. I think that's a great area to study. Engaging it and then prehabbing in the face of depression or opioid, we'll call it overuse, is obviously going to be a challenge. In general, I think what we have implemented probably pretty universally across certainly the ISSG, and I think a lot of institutions, is getting people to come off or minimize their opioid use, which probably helps a bit in the process, but not a lot of direct psychiatric intervention to get them on antidepressants or those sorts of things to mitigate its influence, a negative influence on prehab. So there's a lot of work yet to do, I think, in tying those together and creating systems and processes around managing that. But it's a definite buyer beware situation for the spinal surgeon to engage surgically when you have that combination of factors as a headwind.
Now we have two major medical systems here, Scripps and WashU, with very sophisticated subspecialties in all regards. When I grew up as a younger surgeon at the University of Washington, we had a multidisciplinary pain clinic. Actually, surgeons were part of that. This was done by an anesthesiologist named Paul Bonica, and then John Lozier, a neurosurgeon, led that with great success. And then it blew up. It went away because it was too expensive and nobody would pay for it. Have we lost out on not having multidisciplinary, truly integrated spine centers? Should we as spine surgeons try to reinvigorate that? Since you have the microphone right now, maybe you go first and then Dr. Molina can go second.
I would love to see that, but it is an economic reality that it's hard to fund such a thing. I think that we have historically even tried to garner anesthesiologists who are not immediately part of our group, and without the financial support and incentive, it's incredibly hard to bring individuals together for hours a week to deal with that sort of matter. There has to be funding in place, and I think we can go to bat for that. I think there's rationale for it, but the onus will be on us to prove out the cost value, the cost benefit of creating that kind of system. And I suspect it's there on the cost savings basis to avoid surgery on those that struggle or fail. But I don't see the systems easily accommodating that without us professing and probably even generating some analysis that it is of cost benefit, much like we have done historically with managing bone health, osteoporosis after fragility fractures, and that turned out to be a real cost savings for health systems, but it took a big Kaiser analysis to get us to that point. So I suspect we'll have to do that on our backs.
WashU, Dr. Molina, how's that working for you?
I can't disagree at all with what Bob just said. It's quite difficult. We have a neuropsych group who has actually been quite open in saying, listen, send us your challenging patients, people with chronic opioid dependence, overt signs of depression, any signs that they don't understand the gravity or magnitude of their active disease process, and or they're dealing with it in an unhealthy mental health way. And despite this resource that we have available to us and us trying to get patients there, it seems that patients are extremely non-compliant with trying to get there. So we'll refer them to it and they don't go to the meetings, the group sessions. The ones that don't follow through with the planned interventions. And so it's not on, and I don't know if we can ethically do this. Sometimes I've thought about saying, look, if you don't go through with this, then I'm not going to do your treatment. And there's some element we can do with smoking cessation and things like that. But haven't quite yet gotten to the point to say someone who's very debilitated with, severe pathology to say, look, if you don't do this, I'm not going to treat you. But perhaps that may be where we need to go.
Hey, we have Dr. Basim Ishak with us. He's a neurosurgical colleague from the University of Heidelberg and now also in Wiesbaden. He's published more on doing spine surgery on octa and even nonagenarians than anybody I know in a variety of settings, trauma, oncology, et cetera. And one of your conclusions always, Baz, is, and thank you for joining us from Germany, is to counsel patients and their families. And that obviously sounds good, but what are your experiences and what should we counsel patients on in terms of assuming or sharing risk? Where does that shared decision-making component come in when we have frail patients, and specifically in your case, in octa and nonagenarians, which you've been forced to treat in greater and greater numbers like we all?
Well, thank you for having me today. It's always a big pleasure to see old friends. And what I always want is not only to call the relatives, I want them to have them in clinic. So the direct relatives. And to be honest, often the patients are really clear-minded, right? So they fully understand the complication. When I talk about whatever, let's say it is C1 fixation where everything can happen, right? So I talk specifically to each and every one in this room, and I talk to him, listen, this could happen. I may injure the spinal cord, I may injure the artery, I may injure this and that, and you may end up on ICU, and probably whatever can happen, right? So I'm very detailed in my explanations, and I want to have them all on board, and I'm always documenting on my in my system that I've talked to the patient, to his relatives, and to and who was also in the room. Usually it's also a fellow with me.
So a family group or closest next of kin group. We've seen something a lot here that may be a US phenomenon, and I think I can speak for my colleagues in San Diego and San Francisco and St. Louis as well. We've seen a lot of isolation, a lot of people who live alone and they've kind of disintegrated from their family, and it's very heartbreaking. Is this a phenomenon in Germany, or are you able to kind of gather families and decision-making bodies around patients?
Well, it's actually not always possible, to be honest, right? Sometimes there are just lawyers who are responsible for this patient, right? So, and sometimes the patients have dementia or something. So if it's an emergency, we have to discuss it with the lawyer or whoever is taking care of the patient. Sometimes it's not the relative, and we have to talk with him. Of course, he's not related to whatever and with no emotions, but this is the only way to go.
And you mentioned the dementia word, and this is something I want to have all three of you chime in. We're seeing more and more patients who have some component of dementia. They're still with it, they interact okay, but they have clear cognitive deficits. How should we weigh that in our decision making, assuming that they can still sign their own checks, but there's a diagnosis in the chart and they're not quite with it, they're not 100%. So how much does neurocognitive capability weigh in your decision making to do surgery, sometimes bigger surgeries versus not?
This is very, very important because it has medical legal issues. So if we have a feeling that the patient has some part or some kind of dementia while we're talking to him, we have to bring on a psychiatrist to make an official analysis. Can he sign the document or not? So after the statement, we let him sign, or we have to look for the lawyer or for a judge to take care of the documents.
So very formalistic. So neurocognitive capabilities, let's go to St. Louis. So Dr. Molina, neurocognitive capabilities, how does that affect your decision-making to possibly engage a patient in a very major surgical discussion?
So first and foremost, if somebody is so demented that I think that they're incapable of even consenting or understanding the gravity of the procedure, it's unlikely that they even need that procedure. It's unlikely that they need that type of restoration of function. Often these deformity procedures are for people who want the ability to be able to be upright and exist in the world and not be sedentary. If you're demented and sedentary, you may not necessarily need this. Now, if it's borderline, if they go, I'm starting to be a little forgetful and things like that, but they obviously understand the implications of what you're talking about, the high complication rates, the limitations in function that come with having a rigidity in a significant amount of their spine, but they're already starting to show signs of dementia. I think one of the very important things to discuss with them and their family is that this surgery is going to precipitate a hit in an acceleration of that dementia. That length of surgery, that stress to their body, their nervous system, they're going to be a little bit more demented than the day prior after they get out of that, ICU stay and long hospital stay and rehab. So I have found anecdotally, I can't say that I've researched this, that people really do take a hit in their cognitive function. And their families say that sometimes they don't quite come back to baseline. And they need to know that that's a real possibility.
A great answer. Anything to add to that, Dr. Eastlack?
Not a lot. I think for me, if they're anything beyond sort of early neurocognitive dysfunction, I tend to hold off unless they've got something profoundly neurologic and progressive that is going to limit their life and significant function. Now, having said that, I do acknowledge too that if patients are severely disabled functionally to the point that they cannot be active, I think that has a negative consequence or impact on their cognitive function. So there's a little bit of a balance in that early stage, and typically we'll do neurocognitive testing just to get a sense of where they're at, have the discussion with the family. And that's where the family support's, in my opinion, particularly important. If the family is totally disengaged from a patient that's got neurocognitive dysfunction, I'm much less apt to intervene because they need more support around the perioperative time period. And if they are sort of less disabled, I'll say, from a functional status, I'm less apt to intervene. So it's this combination of seeing that we can get them more functional so that they can protect themselves from more neurocognitive or more rapid decline, that I'm more apt to get engaged in. Whereas a mild to moderate physical dysfunction with neurocognitive deficit, I'm less inclined to get engaged on with them, because I think that they do take a hit, as Camilo said, and then they're sort of swapping one bad thing for the other, being a little better. So it's a balancing act, and I don't have the right answer beyond that.
So great points. Are you ready for a couple of cases from our fellows and hack at me and my partners, Dr. Skuin is here and Dr. Kramer?
Sure.
I'll call on Oliver to come up there. So this is a patient of mine, and to take the great tension off, it was a failure. And I'm ready to receive your sage thoughts. Oliver's from Penn State, neurosurgical colleague. Great to have you here.
Good morning.
And can we switch to the slide presentation?
All right, so this is the first case I'm presenting here. This is a 74-year-old female with a very long list of past medical history: diabetes, heart failure, Parkinson's disease, osteoporosis, who was on treatment, had a previous stroke, fibromyalgia, depression, and numerous previous spine surgeries. Most recently, she had a T10 to pelvis by a outside hospital, and she had chronic pain syndrome and was on Suboxone. So all the difficult comorbidities that make spine surgery challenging. Eventually, she was seen by Dr. Chapman here in clinic. Her posture was severely decompensated, and she had a CT Milo with cord compression and collapse and a kyphosis above her construct at T9 to T12. And I'll show those images here in a second. This was her exam. She was kind of diffusely weak in her lower extremities, had decreased sensation in bilateral lower extremities as well. She did not have any pathologic reflexes, no clonus or Babinski. These are her pre-op pictures here. So you see her previous construct, T10 down to pelvis, and you see obviously the PJF here with the fracture at the upper instrumented vertebra, T10 there. So obviously falling into kyphosis and causing compression at that level. And here are her standing films, and you see even progression of that proximal junctional kyphosis there at that T10 level. So unfortunate patient, obviously all the comorbidities that we hate to see that make it difficult to do surgery on: Parkinson's, depression, osteoporosis. And so our plan here was to remove her hardware, do revision laminectomies, fascitectomies, T9 to L1 for decompression, do intradiscal osteotomies at T10, 11, T11, 12 to and with partial corpectomies to try and obviously fix that deformity, put some inner bodies in, and then extend her construct up to T3 with crosslinks down to the pelvis, and then do a quad rod construct with this. During the case, there was no CSF legal dural tear. She did have a reduction in neural monitoring after decompression of the dural sac, and as well as during the crosslink placement. She started on NASCS2 steroids and her maps were pushed, and by the end of the case, she had some recovery of her signals. These are her post-op pictures here. So you see good restoration of height there, and obviously the extension of fusion. And these are just kind of comparison pictures pre and post-op. So unfortunately, we had this good radiographic post-op picture, but her hospital course was quite complicated. So, she had that decrease in neurosignals during the case, and post-op, she was unfortunately paraplegic with intact sensation. She ended up having to be re-intubated for hypercapnia. She was extubated and then re-intubated for mucus plugging. She ended up with urosepsis. Blood culture were positive. She was started on broad spectrum antibiotics. And then, of course, this was complicated by interventional wound drainage. We tried to do a Prevena wound vac. We did multiple rounds of this. Her wound vac was changed, it kept draining, and eventually she went for an IND and a true wound vac placement. She was continuing on antibiotics, went back to the OR to take the wound vac off and close with multi-layer closure. And eventually, finally, after many hospital days, she was DC'd to a SNF. On discharge, her lowers were anti-gravity at the time, so a little bit of improvement, but a little bit worse than pre-op, but her sensation was intact. And then, unfortunately, recently what we saw was that she was readmitted to an outside hospital for an E. coli UTI and multilobar pneumonia, had thoracentesis, and that's kind of where she stands. The last that we know. So tough case, challenging case.
So if you can go back to the comparison CT, so just a brief explanation. So I do believe in prehab. Our previous partner, Dr. Hanscom, was actually the prehabilitation champion in NAS and did that for several years. He taught me a lot. So we prehabbed her for, I think, almost a year. And she basically still was severely forward tilted. We tried everything, nutritional support, and she came to clinic and basically said, I've done everything you've asked me to do. I'm not going to live like this. I want you to do the surgery. And we obviously did risk counseling. The frustrating thing in surgery is we did not have any major complications, but previous surgeons, as you can see, had done decompressions above that ill-fated fusion. And so we did an extensive scar release, but during the reduction, she had a decline. We did all the escape maneuvers, but signals came back, but there's a clear-cut decline without any clear major mechanical issue. So she just did not pull her respiratory muscles after surgery. It was very frustrating. We detoxed her and everything like that. And she has Parkinson's, and I mean, she's as high risk a patient as you can. So should I have told her no? I mean, I've obviously questioned myself many times about this because nobody likes to harm a patient, certainly not me. And where did I go wrong? Was it decision-making? Was it technical? Any thoughts are welcome. Who wants to fire first?
Jens, what was her degree of Parkinson's?
She was pretty functional. So she's been stable for about 2 years. She's actually very astute brain-wise. So she made a very good statement that she had not deteriorated for 2 years. She activated her buttock muscles, but in retrospect, when I look at her iliopsoas specifically, it was like 0.8, so it was weak. But she had reasonable buttock muscle activation, again, very feisty character. Mm-hmm. So not great. I have high degrees of worries about Parkinson's patients. Let me just tell you that. But yeah. It was one of those gray zone patients I'll end with.
Yeah, no, those are tough. Parkinson's for me is a red flag. If they're mild, and unlimited meds, pretty functional, then I tend to see them do okay. But it's challenging even when they're mild. So with deformities, I'm pretty reticent to do them unless they're progressing neurologically with deficits in an aggressive fashion. And even then, if they're on the severe end of the spectrum, I just generally tend to say, this spectrum or this part of the spectrum is not going to do well. I don't want to be the one that pushes you over the edge because the disease is going to take you there. Even just with the anesthesia, they do poorly. But it sounds like you did great prehab. I'm surprised she lasted that long and was engaged that long.
I think I heard that from Dr. Molina earlier, but I said we have a very algorithmic prehab program, and many patients just don't hit it or meet it, and I tell them, sorry, I can't do it. And I have no problem saying no, but in her case, I looked her in the eyes, and she said, I want this done. I'm not going to live on like this. Dr. Molina, do you have an algorithmic prehab program, and how, in this hypothetical scenario, would this patient have fared in your prehab regimen?
No, like I said, my algorithmic prehab program is usually optimizing their bone health, optimizing their nutrition, and during that period of time, I expect them to participate with physical therapy, specifically with core and extensor muscle training. I also write them orders to focus on their proximal muscle strength. I want them to strengthen those muscles because I have found that invariably, in some way, shape, or form, if you're doing a deformity correction, those are the muscles that end up being weak. It's either through the stretch of the lumbar plexus, stretch of the psoas, or direct irritation to those nerve roots. The majority of the time, it's whether you're doing an L4 or L5 PSO, those proximal muscle groups end up being the most impacted. You know, to not even think about what the surgical plan or the execution in any of these patients, and I tell my patients this all the time, if there is a failure to mobilize relatively soon after surgery, you know that that patient is not going to do well. And it can be something as severe as this, where they're paraplegic and they're barely anti-gravity and they're obviously not going to mobilize. All the complications follow after that. But they can be just subtly weak. If they can be 4 minus or 4 plus, or even have great confrontational testing when they're in bed, when you test their strength. But if they get up, often they're, if you do one of these big deformity corrections, they feel off balance. They feel like they say my legs feel like rubber, and they need a walker or 2-person assistant, things like that. And I really push them on those things, because if they linger in bed, everything that you just described, this whole story, plays out pretty consistently. And to circle back on your question, knowing that is the biggest risk, I think, for them not doing well on the short term perioperatively, I really focus on rehabbing those specific muscle groups, because I think their ability to mobilize makes a tremendous impact into whether I'm going to be showing standing x-rays for that case or a long segment or CT reconstruction of them supine.
All right, so Dr. Morozynski, thank you for that presentation. I think we have 2 more cases to show. Do you have Hagai's cases?
I don't.
Okay, Mohsen will come up. Dr. Karami will come up. 2 of our fellows had to run down to the OR already, so apologize. Thank you, Dr. Morozynski. And we have Dr. Karami here, orthopedic colleague, and previously pediatric trained, so it's a cool background. Very broad scale thinker, and he's just being tasked to improvise. Dr. Amster Khan's cases were given upon him because Dr. Amster Khan was called into the OR. Do you see where you're going, Mohsen? And this is Hannah. Thank you, Hannah, for being here. And also I recognize Ben in the control room for putting on the shows. Hannah Kennedy has been a great addition, and she's developed great tech skills. All right. So let's ask a question to my partner, Dr. Oskoyan. Interdisciplinary conferences and having colleagues. So our larger referral centers have the good fortune of having more than one colleague here. Can you tell us a little bit about having second opinions, encouraging patients or their families to have second opinions from partners?
I mean, I think we all do it. The problem is that ultimately, who owns the patient? And I don't know how it is in other systems, but at least in our system, our physiatrists, and then, we kind of have all our own silos. And it's difficult to even get the PCP engaged in terms of, who's going to manage the osteoporosis. They get kind of shuttled back and forth between specialists. Whether it's endocrinology clinic, or we have a really good pain interdisciplinary program, but I think that's the hardest thing I have. I don't know about the rest of the
I might offer something up that we implemented down here that really changed our lives considerably with the bone health side of things. And this gets back to what we talked about earlier with the resource and it really is a time sink for the endocrinologists and the rheumatologists who often manage a lot of the bone health from a primary care referral perspective. They just simply do not want to deal with the bureaucracy of anabolics. There's a bit of a time challenge for them. So we struggled for years doing that, going through that pathway, even aligning with a few of them. And we stood up what's called a farm deep program. We call it APP, but it basically is a set of doctors of pharmacy who are empowered to take our referrals and get patients shuttled through the authorization process and ensuring, of course, that there's reasonability from a medical perspective of using anabolics. And that turned the wait times into, I can get people in within a week. They're on anabolics within a week or two, instead of making special calls and saying, can you get this patient on, or having them wait 6 or 8 weeks to even be seen. And then the delay of authorization even further. When we're trying to implement these anabolics for 4 to 6 months before surgery, if you tack on another 2-3 months of bureaucratic challenge, sometimes without success, it's really meaningful to patient care. So that kind of systemic approach really has been a boon for our spine and orthopedic services who rely on that fragility care and prehab.
That's brilliant. I mean, we definitely need some new approaches towards how to handle the bone health things. We have the same problem. We had one colleague who could simply not handle our flow of patients. There's no system solution. And then this colleague, out of protest, retired, and we're in a big void. They've tried to hire some other people, but they just don't like it. And so having a novel solution, trained APCs, or I'd like to talk to you more about your systems approach with a PharmD that's empowered. Really cool. Dr. Molina, interdisciplinary or multi-colleague consultations within the system to discuss complex patients and ownership of these patients. How does that work for you?
We have multiple things that, we have joint conferences between the orthopedic and neurosurgery spine groups to discuss some of these patients. And if we find that somebody has a unique expertise in one particular approach, which is something we foster here, somebody's really focused on endoscopy, someone's really focused on spine tumors and deformity, someone's really focused on MIS and things like that, we find that the patient can get redirected to somebody who's a content expert in that. So we're trying to minimize the jack of all trades model. We also have joint conferences with our pain group and our interventional physicians, and can sometimes find pretty efficacious non-surgical strategies for people who may not be great surgical candidates at the time. And in terms of our, preoperative optimization, we have a little bit of perhaps a cheat code where one of our nurse practitioners joined the bone health group, and she sees all of our patients quite expeditiously, and is pretty deferral to us in terms of the anabolic that we would like to see them on to get them ready for surgery.
Great point. All right, final case. Mohsen, take it from here.
Yeah, sure. Good morning. This is a 60-year-old female. So presented to our clinic for lower extremities weakness and pain, especially on left side buttock area. She used to be a nurse, but gradually stopped working because of the pain, especially when walking and standing and even sitting. She had a kind of past medical history of osteoporosis and multiple surgery for her back in the past. Deformity correction using Harrington rod in 80s, and then fusion L3 to S1 because of the pain in 2010, and then after that, because of the L1 fracture, was treated with L3 to S1 fusion. And so this is the X-ray of the patient, and CT scan. You see the growing rod was there, still there. And then the surgeon rather not to touch the Harrington rod and just put the screws and cage from L2 to pelvis. And then so the Harrington rods were like.
It's not a Harrington rod, by the way.
Yeah.
This is a Moss Miami rod, but that's okay. Go for it.
Yeah, this is the CT scan. You see the video here. And then there is kyphosis due to the L1 fracture with deformity.
So the editorial, as Mohsen does not know this patient, this is a previously incredibly functional person. It's a nurse who works as a professional first assist, hiker and everything. And she had this fusion done by a surgeon who doesn't do a lot of spine surgery, so not complex spine surgery. He just the shortcut cut the caudal end of the deformity rod that she had done in her 20s, I guess, out and instrumented below that. And she became progressively deformed. Can you just show that? And the problem with her physiologically is now, so she's tilting forwards and to the side. She's become osteoporotic and she's become opiate habituated. So the deformity was treated with this wonderful cocktail of opiates and increasing inactivity. And so she came to us pretty sarcopenic. You can see she has terrible bowel dilation just from chronic constipation. And here I have a real mess, a discontinuous hardware system with a cold flow. We have a bone scan that shows a moderate increase, not an acute fracture of L1, but that stress area that was created iatrogenically by cutting one rod off and not linking has kind of collapsed more and more. So questions here are, again, and we'll briefly go into surgery later, but you have a patient who is extremely functional and whose surgical intervention has kind of had a misadventure now. And she's now osteoporotic and opiate habituated and has become immobile, a common concurrence. So I'll ask a very provocative question first to either who wants to take that first. Who should do deformity surgery? Should this become more center-based? And I'm referencing the UK here with the Get It Right the First Time NHS initiative, where they calculated that if a center doesn't do more than 40 surgeries a year, they should probably not do surgeries because they get so much more common complications. So who should do deformity surgeries? Who should see a patient like this? Should this be a center like Scripps, like WashU, like San Francisco, or should this be open for anybody who wants to take it on?
Well, I would like to start because it's a common issue in Germany right now because they're changing the health system. Like, in my opinion, it should be done by a center. And now the system this year changes in Germany as they say, if you're not performing more than 200, 300, 400 of this case, you're not allowed to do the surgery. But if you do it, we're not going to give you money for that. So the insurance would not pay. So this is how they right now change the system in Germany.
Wow. I did not know that. That's incredible. Yeah. So what are the thoughts of our other colleagues? Thanks for saying that, Baz. That's really interesting.
Go ahead, Camilo.
Yeah, so
I think we would all like to be, dogmatic and say, oh, only experts should do this or that. But I think we have a couple of issues in defining exactly what is deformity and what severity of the deformity needs to be treated somewhere. I argue that even a degenerative L4 to S1 pathology, if not done correctly, can precipitate a deformity. And so by that logic, I would be saying that needs to only be done in a specialized center, which is obviously crazy. So I think we have those issues. The second thing is, rather than being exclusive to it, rather we should be training people to be able to handle the majority of these pathologies, and with their only potential limitation being the resources that they have available in their facilities, not necessarily their knowledge or technical skill.
Okay, that's fair, an open model. San Diego, what do you think? I mean, you have obviously an epicenter of really sophisticated deformity surgeons there. Do you see these kind of collapses, literally and figuratively, these failures? We all have failures. Let's just put it this way.
Yeah.
Predictable failures in your system?
Absolutely. Even within, we certainly get them from without, but to some degree, there's gray zone, I think, in just educating people. I think our people that are just managing degenerative spine don't have that appreciation of removal of fixation and progressive deformity in that setting. That's just one sort of educational paradigm that probably needs to get out there. And if you're intervening in the setting of deformity, there's probably some rationale to have some input and not doing it in isolation. I think the benefit of centers like ours and yours and Camilo's is we're often discussing these cases amongst one another. So we learn from one another's mistakes and we can kind of shepherd the right decisions. The challenge I see with these out in the community is they're often done in a single decision manner or single decision maker manner. And I think that's where you just get more error. So bottom line is we need to educate, and I'm hopeful that as we progress in our deformity understanding through all these study groups and metrics assessment, and I know it's a moving goalpost, that will promulgate into the deformity community and then the degenerative community. And I hope that as a large community, we do a better job even on the community basis.
I think those are wise words. So in this case, we'll take it forward because I know the patient Molina is just thrown into the fire here. I was actually very harsh with her. She had to get off Suboxone. This is a medication I truly fear. I've had terrible problems with it in postoperative management. And we converted her to short-acting medication I was comfortable with. And she actually went on a very primitive but a protein-enhanced program. Being the former athlete, I put her on a recumbent bike and I challenged her, and she actually did a great job with that. So we commenced with surgery, and I'll ask Dr. Eastlack maybe, because you've done terrific lectures here at SSF, how would you treat this? So we have a three-dimensional L1 pathologic slow creeping fracture below a thoracic instrumentation that was fully fused in the past, and then a short segment, I think it's L3, I forgot what it was, L2, yeah, L2 to S1 pelvis fusion. How would you treat this? It's a three-dimensional L1 deformity now. The surgery speaking. Bob?
Sorry about that, I was on mute.
Oh, yeah. So three-dimensional, just quickly, we're not focusing on surgery in this session, but just we detoxed her. She actually responded. She drank whatever her muscle cocktail was, her anabolic substances. She did actually pretty faithful, and she actually felt better, but still had pain. So how would you treat this three-dimensional deformity with an L1 pathologic stress fracture kind of?
Yeah, I mean, I think you're in three-column land. You'd have to do a biplanar correction through that area. And then if you can, I typically try to work around the rods if they're caked in there, caked in bone, using screws around them from a lateral to medial position. Sometimes you could put hooks in the fusion mass, but essentially connect with that old construct, but do a biplanar correction through the area of failure to correct the sagittal and coronal planes effectively. Whether that, I don't have all the numbers, but I would hope you could do that through just a PSO rather than a VCR, but that may be necessary depending on the degree of correction required.
So one thing in this patient, Dr. Molina, was she had a BMI of 19 when she first came. She was that malnourished. Again, this is a nurse who works professionally as a first assist. And she'd just fallen off the rocker. Is there a BMI as a simple current serologic parameter that we can use to tell a patient no, like a BMI, a lower BMI cutoff, a protein cutoff, something like that, serum albumin cutoff?
I don't think there is a marker that you absolutely can say no to.
Your thoughts on fixing this? Is this a comprehensive redo? Is it a local redo?
Do you have standing films? Can I see standing films?
Yeah, we tried to find those. We did not have good standing films. They are in a different folder, so this is not Dr. Karami's fault, but there's a pretty pronounced forward and sideward, basically a kyphoscoliotic collapse. It's pretty substantial.
And this is imaging 3 years ago and these are supine films, it looks like?
Yes. So we have standing films when she came to us finally, and they're pretty profound, but they were not available to the fellow. I apologize for that. So
that's okay. And it looks like the fusion was to L3.
Yes. The surgeon did the right thing, but the hardware was not contiguous. So there was CT evidence of a fusion, and then L1 just basically settled down more and more and more.
Yeah. I think people have said this before. And I would argue this is likely a problem more in neurosurgeons than orthopedic surgeons. This idea that because it's fused, that if you just anchor to it, the rest of the bone is going to hold everything up. But the reality is that bone is a living organ, just like everything else. And you're creating two lever arms, even if it's fused, there's still going to be a differential load from the proximal and distal construct. And it's not a surprise that this patient is going to develop this, kyphoscoliosis proximal to the distal construct that is much more rigid than the proximal construct. And just like Bob said, this is, for me, given how rigid this is, a 3-column osteotomy across L1, and finding ways to link into those old rods. I don't particularly think I need to take her all the way up to putting screws all around the old rods and making a whole new construct in proximity to this, but I would just find a way to link into those old rods and do the 3-column osteotomy at L1 where there's the focal kyphotic point.
Great. Okay, so take us to the end here because we're at time. So we actually did a full vertebral VSO, so a class 4 kind of a redo corpectomy. And we did bridge, we took out the old hardware and bridged it, but did a 4-rod construct. And she actually did quite well. So this is a success story. If you can go through the sagittal images one more time, Wilson. Thanks for taking that. And we have a standing film from her, I think a late standing film.
That's all.
There should be some late scoliosis films. Yeah, so she's like 2 to 3 years out now, and she was actually very grateful, very happy. I was very worried about her soft tissues. You can see how thin this woman is on the lateral standing film, but she was actually very grateful. And she is off opiates, and she's resumed a very active lifestyle, but I was very worried about her integument dorsally just because she had just literally become so infused with opiates and had become very passive and did not put appropriate nutrients in her body anymore. So thoughts, criticisms, too much? I mean, it worked out in her case, but it was certainly kind of a little breathtaking for me to watch the soft tissues dorsally.
I think the attention to the soft tissues is probably understated here. We're all looking at the alignment and the correction, but you can see how close the instrumentation is to her soft tissues. And that thankfully, it sounds like it worked out well for you. Did you use plastic surgery at all to get paraspinal
We used to have
muscle
plastic
elevation?
surgery, but our system has again decided to do cost cutting, so we don't have a posterior reconstructive soft tissue surgery anymore. We actually did use a plastic surgeon for this case, but as of now, we're devoid of this resource. Again, cost-cutting measures have brought this, and a lack of systems thinking.
Got it. Yeah, so I think excellent result. Sometimes I think twice about doing a complete VCRs in these because there's not going to be a defined end plate above and below for you to land that cage on without the risk of subsidence. So if possible, and when I simulate the corrections, if I think I can get it enough across the 3-column osteotomy, like extended PSO, where I can close the bone on bone, I tend to favor that in general for long-term healing. But I think this looks excellent.
We're at time. If we can go to a survey shot again. So thank you, Mohsen. I want to really thank the SRS Task Force for Sarcopenia and Senescence. I want to thank Dr. Ishak for joining us from Germany. And a special thanks to Dr. Eastlack and Dr. Molina, as well as the future Dr. Bowie, for excellent presentations and very thoughtful conversations. It's been a great honor for SSF to host you. Bob and Camilo, do you want to give us closing comments?
Good, Camilo.
I just appreciate the opportunity to share our work that we've been doing with the SRS, Senescence Adult Deformity Task Force. If you cannot tell yet, just to bring the point home, we are at the complete birth of this spinal sarcopenia field. We obviously have almost essentially no means to make this a modifiable risk factor, but I do think in the future, just as we have been applying anabolics to bone health, and we've been applying biologics like BMP and other synthetics to improve our fusion rates, we are at the birth of thinking about biologics and anabolics to augment the muscle soft tissue envelope support to our spinal constructs.
Well stated. Dr. Eastlack, I think we have a second session coming up with the SRS. Do you want to talk about the summary of today and then outlook for the future?
Yeah, so we talked obviously primarily about sarcopenia today in the context of senescence and frailty. The next session will probably incorporate a bit more bone health, some of the the review on that topic and where we are, where we're hopefully headed. And if we can incorporate some of the biomarker work that the SRS looked at as well, I think that'll be informative to you all. But hopefully, this gives you a sense of the importance of the topic, and very importantly, starts fostering that curiosity to research it and develop our skill in managing the issue going forward through that research and scientific discovery.
Well, thank you all. Thank you, SRS. Thank you, Camilo, Tim, and Bob for great presentations and thoughts. And till next time, thank you.